In this video, we'll present the treatment of a wide neck basilar artery aneurysm using the neck reconstruction device, pulse rider, and coiling. The patient is a 68-year-old gentleman who was found to have a large basilar artery aneurysm during workup for sinusitis. However, he had significant past medical history of hypertension, diabetes, coronary and peripheral artery disease, atrial fibrillation, and severe COPD. He had past medical history recently of right femoral artery bypass stent, left hip replacement. He also was recently admitted for DVT and pulmonary embolism. His current medications include aspirin, Plavix, and Coumadin. Due to his comorbidities, this patient was not a good candidate for surgical clip ligation. For this wide neck basilar aneurysm, endovascular options could be a wide stenting or another novel end device such as the pulse rider. So under conscious sedation and right radial artery approach, we maneuver a 6-French benchmark guide catheter into the subclavian and into the right vertebral artery. We maneuver this catheter very distal into the V3 or almost V4 segment of the vertebral artery. Through this benchmark catheter, 2 microcatheters can navigate easily, a 021 and a 017 microcatheters for the device and for coiling. Here you can observe the large aneurysm, and we are obtaining measurements for selection of the pulsar rider. We are obtaining access first with the catheter that is going to take the device. In this case, we select a T configuration device. There are 2 of them, a T and a Y. We decide to use a T because the less than 90-degree angulation of the posterior cerebral arteries in relation to the aneurysm neck. Here you can observe the device that is coming out of the microcatheter, and slowly we are advancing the device as we unsheath the microcatheter in order to have both limbs of the device into each posterior cerebral artery. The device is expressed slowly and let it take the configuration into both branches. Once we have adequate position of the device, we then maneuver another microwire followed by another coiled microcatheter inside of the lumen. We usually involve 2 surgeons while we are doing this type of procedures. One surgeon is in charge of deploying the stent or the device and holding in place, while another second person is maneuvering the coiled microcatheter and deploying multiple coils. We initially start with a 3D coil or framing coil large enough to accommodate into the aneurysm. Once we have adequate framing coil, we then slowly fill up the rest of the aneurysm. As you can see how the pulsar device is protecting the neck and both posterior cerebral arteries by not allowing the coil mass push back into the parent aneurysm. We progress with multiple coils. This is a large aneurysm that requires significant amount of coil. What we want to achieve is a really good Raymond-Roy 1 result. We advance in more coils until we feel that we have achieved a pretty good coil compaction. We then perform an angiogram demonstrating excellent results with adequate coil compaction and preservation of both posterior cerebral arteries and basilar arteries. At the end, once we have successful coiling, we detach the device electrolytically. Thank you.